When I was young, I could never have imagined that either set of my grandparents were busy knocking boots, boning, hooking up, doing the nasty, pillow biting, getting it on. That's because they were grandparents. They weren't supposed to be sexual beings. But today, I wonder if they were, or would they have if they had today's modern technology. Welcome to Mating Matters, the podcast that looks at all human behavior through a lens of evolutionary psychology and human mating strategy. I'm Dr. Wendy Walsh. Sex as a behavior isn't just for reproduction in Homo sapiens. We use sex to reduce stress. We use sex to give us pleasure. We use sex to maintain bonds. Some people use sex to social climb, or as a currency, or to exchange care. Sex has so many functions in our species that long after our years of reproduction, it still can be very necessary. My guest today is somebody who, specializes in mature women's bodies and their very active sex lives. Her name is Dr. Mary Claire Haver, and you've probably seen her on Tik Tok with her 2 million followers. She specializes in menopausal medicine and female reproductive health, as well female sexuality across the lifespan. Dr. Mary Claire Haver, it is such a treat to have you on Mating Matters. I know I've been following you on social media for a long time, but to be able to have an intimate conversation about women's sexuality is a real treat for me. So thanks for being here.
You're so welcome.
So let's start by talking about how you got into the area of menopausal medicine and also why sexuality is important even post-menopause.
I wish I could give this altruistic explanation, but it was very, very selfish on my part. I was suffering tremendously through the symptoms of my own perimenopause and menopause and realized the gap in my training, that I had not been trained appropriately to take care of myself, yet alone anyone else, and kept hearing the voices of my patients all these years where I kind of threw up my hands and was like, well, welcome to getting older, until it happened to me. And so once I'm embarrassed to say it, but I'm just trying to be honest, once I went through it or started going through it and realized, I don't know what to do here. I don't know the best treatments. I just started reading everything I could get my hands on, talking to colleagues across different specialties, and decided I wanted to focus on this to be a better clinician to women our age who are suffering needlessly.
In an earlier episode of Mating Matters called Darwin's Golden Girls, we interviewed the scientist who came up with the grandmother theory and this idea that our very long life expectancies, that for women, human women, come with a third of their life where they are wise, energetic, experienced, smart, beautiful, and sterile, was sort of designed by natural selection to allow to have grandmothers around helping with grandkids, etc. We also know, and I've talked about this in many episodes of Mating Matters, that sex for human beings has so many more purposes than just reproduction. We know that it is used to maintain bonds in intimate relationships. It's used for social climbing. It's used as an exchange of care. It's used as a stress reduction. It's also used just for plain old pleasure. So there are many reasons. Now, when your patients come to you, and they've hit this time of menopause, what is the chat you give them about should they pursue medical interventions to keep their sexual health alive? What do you talk to them about?
I open the conversation with them, which for a lot of them, no one's ever asked them about this in their entire medical journey, throughout their entire life. No one asked about their satisfaction with their sex life, if it was affecting them, how it affected their partners, what is their level of concern about this. So that is one of the standard questionnaires that I have with my patients in the menopause clinic. And probably about 80% of patients admit that things are not going as well as they hoped.
Mm-hmm. One thing I've heard is, correct me if I'm wrong, up to 50% of women experience vaginal atrophy. Can you explain what that is?
Yes. So as we go through the changes associated with perimenopause and menopause, our estrogen levels by and large drop. And then once we're postmenopausal, they kind of bottom out and are basically undetectable. It turns out the tissue of the, and I'm going to use very, real medical terms here. So if I'm offending your audience, I apologize. But the tissues of the vagina and vulva are heavily inundated with estrogen receptors. And it turns out when the estrogen receptors are stimulated, our tissues are thick, healthy, they have tremendous amount of mucus production, they have increased blood flow, and they are much less likely to become infected. Your chance of urinary tract infection is much lower, sexual infection is much lower. And then when we go through menopause, the tissue thins out, mucus production drops dramatically, and the elasticity of the tissues decreases. So you end up with a smaller, tighter vagina, but it's very, very thin and much, much more likely to become injured or infected from just routine intercourse.
Well, you can use medical terms, but I'm going to use lay people's terms, okay?
Sure.
I used to think that vaginal atrophy just meant that you could accommodate a much smaller penis and be happy, that it just shrunk.
No.
But actually, I've learned that the walls of the vagina become so thin that a penis feels like a razor blade. Okay.
Exactly. It definitely can. And 100% of us will undergo some degree of vaginal atrophy. The tissue will never, will not be the same without treatment. And the degree of which that causes discomfort to a patient can vary, but all of us will experience some form of vaginal atrophy with menopause.
So before we get into the treatment, let's talk about age, because I notice in your social media you talk about perimenopause as much as menopause. Can you define both of those and explain the ages that they show up?
Absolutely. So menopause, in the medical terminology, is one day in your life. It is exactly 1 year after your last menstrual period. Well, what if you've had an ablation or a hysterectomy? How do you define that? So it is 1 year after the cessation of your ovarian function. And it is basically the time in which your periods aren't coming back or your ovaries are not going to wake up again. So the transition from normal ovulatory reproductive function to full menopause is about 7 to 10 years. So average age of menopause is 51. However, normal is still 45 to 55 years of age. So it is completely reasonable for a 35-year-old woman to begin to experience some of the changes associated with perimenopause.
You want to hear a story? I had my second baby when I was 41. I nursed each of my babies for 3 years. I was breastfeeding and having menopause at the same time.
Yep. Absolutely. Bless your heart.
It was wild. It was a wild ride. So there is this convergence, and it can happen younger and younger. Now, it is a normal. Here's the other thing I think a lot of people, especially men, don't realize is they think the menopausal process is like going through puberty. It's like one summer where you suddenly got your period and got 6 inches taller or your voice lowered or something, and it takes about 6 months.
You got breasts and pubic hair, and
it was all so fast. But now, I mean, I'm probably 10 years into hot flashes going, so they really just don't go away so fast. No. It's a long,
they can last
slow
12
process.
plus years. It's a very slow process. Yeah.
So let's talk about sexual function and treatments. Now, before we do this, I want to talk a little bit about the relational things. What we saw in our history as far as treatment for aging sexuality tended to be male-oriented, right? We came out with Viagra. We came out with all kinds of other things. Recently on my Los Angeles radio show, I had a urologist on from Boston Scientific talking about all the treatments for erectile dysfunction. And I'm telling you, there are a lot. But it was late coming to the table for women. Why is this?
I just think that women's sexuality has been undervalued, has been treated as this mysterious disease. It's not as clear. It absolutely is not as clear cut as it is for a man. We talk about reactive desire and spontaneous desire. When we look at a woman's sexual function, if she has an issue with it, it's usually one of 5 causes, and there definitely is overlap amongst the 5. The first is there a relationship issue? And you probably are better at this than me. If there's no emotional connection, very few people are going to feel that they want to have physical intimacy with someone they're not emotionally connected to, at least women. Number 2 is a desire issue. That is what happens in our brain. I have women who come to me that they love their husbands. They're wonderful, magnificent partners in life, but there's just not something in their brain that seems to be firing that they want to be intimate with them. The third thing is an arousal disorder. Arousal is what happens in the pelvis. It is a physiologic response to a stimulus. So you have lengthening of the vagina, increased blood flow, the clitoris becomes enlarged, you have increased mucus production. But these are all treated differently. And then we have orgasmic disorder, where someone just cannot, no matter what, have an orgasm, or it's very delayed. And then finally, a pain disorder, where usually due to vaginal atrophy or vaginismus, they have so much discomfort with the act that their brain shuts down. They don't want to have it. And you can have an overlap of 1, 2, or all 5 of them.
Recently on Mating Matters, we had the woman who finally came up with the answer of why we evolved to have female orgasm. Because in the past, the thinking was either it's the pump down theory, pump some eggs down, the contractions are somehow pushing eggs down, or the suck up theory, somehow orgasms are supposed to suck sperm up. But actually, she, in her very reliable research, determined that our clit is a tiny little remnant of a penis, no different than a man's nipples. And we do know that there are men out there that have a lot of sensitivity in their nipples and plenty of men who do not. And in the same way, she feels that diagnosing a woman as a dysfunction when she's non-orgasmic would be the same as saying to a man, what, you can't orgasm from your nipple stimulation? Right? So it really exploded this idea in my head that we put a male model of sexuality, cast it on women, and then tell women there's something wrong with their bodies.
With them. So this has been proven, this exact thinking of we're taking the male model of everything health-related, including sexual medicine, and layering it over onto a woman. And when she dares to not follow the male model, it's abnormal.
Right. When we know, for instance,
just done heart attacks. It's one of the best examples. The way a woman presents in a heart attack is different than a man. We don't have the chest pain, shortness of breath, left-sided, all the things I was taught in medical school. And it's always been thought to be a woman is just abnormal. Except this is normal for a woman. We just don't the way that men do.
For a couple of years in a row, the wonderful organization Hadassah has invited me to UCLA to be the host of their female medical Women's Health Day. And every year there's a cardiologist who stands up and she goes, ladies, I'm going to tell you one thing that will save your lives. If something's going on in your body between your shoulders and your pelvis, and something's off enough to make you go to an emergency room, no matter what, just tell them there that you've got pain down your left arm.
Yeah.
Because you're not going to get your electrocardiogram unless you do that.
Unless you do. Yeah.
You're not going to get the right treatment. I also had on the show Dr. Cindy Meston, a neighbor of yours at the University of Texas, Austin, and she has a female sexuality lab there. And she talks about how much the female orgasm is in our head, just like what you say. It's like you have to psychologically get to a place. And one of the things she explained is that female sexuality is responsive, and a lot of men don't get this. In other words, when a man is in between relationships, he may replace his girlfriend with masturbation and or the use of pornography, whereas a woman's sexuality kind of just subsides. It just represses. It just kind of dissipates because she's busy taking care of kids and jobs and everything else. But then if she meets a guy she's interested in, everything amps up again. And this is how the female sexual response system works. And so women erroneously go to their doctors and say, there's something wrong with me. I don't think about sex anymore. Well, you got no object to work with.
Or they don't like the object that they're working with. One of my favorite books is Come As You Are by Dr. Emily Nagoski. And she kind of breaks down the reactive and spontaneous desire issues between, the mismatch between males and females. And so I usually have a patient go buy the book and read it and then come back to me and say, okay, is this you? And, now do you want to try medication? Do you think this is something that is going to help? After you read this book, and sometimes they're like, this is not me. I really want to try the medication. Or they're like, I realize what my problem is. I just have a mismatch with my partner, and this is something we need to talk about and work through our relationship, before I take a medication that might have side effects.
Because I will say this, my human sexuality professor in graduate school said nothing will kill a sex drive faster than anger. If you're mad at your spouse. For a woman. Oh, yeah. Men, it sometimes amps it up. But women, it's just like if there's relational issues, you can't tell your body to just turn on again.
Exactly.
We're going to take a little break now. You're listening to Mating Matters. I'm Dr. Wendy Walsh. We'll be right back. The Dr. Wendy Walsh Show on KFI AM 640 Los Angeles every Sunday from 4 to 7 p.m., where we talk about everything in relationships, the good, the bad, the ugly, the smart. Whether you are looking for a relationship, whether you're looking to keep a mate, whether you're looking to recover after you've lost a mate, I have the science of love for you. You can download the iHeartRadio app and listen to the Dr. Wendy Walsh Show anytime. You can also hear it live every Sunday from 4 to 7 p.m. Pacific Time on KFI AM 640. Welcome back to Mating Matters. My guest, Dr. Mary Claire Haver, a Galveston, Texas-based, world-renowned OBGYN who specializes in women's sexuality across the lifespan. This episode is called Do Sex Lives Retire? Let's get into menopause and treatments for vaginal atrophy and other issues. Where do you start with a patient?
So I advise lubrication for every woman, regardless of her age or status. I'm like, I love lubricant. It just makes everything better, easier, more enjoyable, more pleasurable, and you kind of already have that system going when your natural mucus production starts declining.
Are some better than others, and are they all safe?
So there are a lot of people who are using natural products. I say natural, like olive oil or coconut oil or Crisco or different things. Just be careful because a lot of those things don't have bacteriostatics in them, and they can become, so you don't want to be rubbing bacteria in the genital area because you'll get urinary tract infections. So a lot of the stuff that is sold specifically for genital use, at least the packaging is such that you can't, it's meant to deter the growth of bacteria. So my favorite lubricants, which I recommend to my patients, are things like Uberlube or KY Silky, which is vitamin E based. Astroglide is another good one, which is silicone based. So I do ask them to stay away from plain KY or water-based lubricants because they do evaporate and they can cause more dryness once they evaporate.
I tried some natural ones and they don't last very long.
Yes.
Right.
And, our partners are taking a bit longer to, fulfill their orgasms. And so you want something that's going to be in there, for as long as it needs to take so you don't become uncomfortable in the middle of the act.
Okay. What about treating the vagina with hormones?
Sure. So here's the good news. Vaginal estrogen works almost 100% of the time. It will build the tissue back up to its pre-menopausal levels, increase mucus production, make everything stronger, thicker, and the number one treatment for postmenopausal recurrent UTIs is not antibiotics, it is vaginal estrogen. The greatest news about this is that turns out vaginal estrogen is such a low dose and it's poorly absorbed into the bloodstream, there's zero risk of increasing blood clots or breast cancer.
Wow.
So it's very, very safe.
See,
yes.
and I was afraid to use it since I'm on hormone replacement. I thought that would be a double dose of estrogen.
It actually, I have several patients that I will kind of amp up their vaginal treatment with a vaginal dose while we're doing systemic. And then once they kind of get to a cruising level, we back off and let them titrate down to the lowest dose possible, or just get off altogether once their systemic is enough to maintain their vagina. But quite often I'll start a patient off on both.
You know, I'm calling my GYN as soon as I finish talking to you. She's on speed dial, by the way.
I hope so.
So let's go to, is the next level Mona Lisa or the laser treatments, or is there something else?
Okay, both the Food and Drug Administration and the American College of OB-GYN are dissuading physicians from recommending the Mona Lisa or other laser treatments. There is not enough evidence to support its use, and there are so many case reports of injury, worsening symptoms, and it's very, very expensive and not covered by insurance.
Yeah, not covered by insurance. So I'm going to give you what's called anecdotal evidence that has nothing to do with general public and public health science. I had chronic urinary tract infections my entire life, probably because as a small child starting at the age of 6, I had recurring kidney stones, and they went up cystoscopically to remove them. So I'm sure my urethra was all damaged, and it was probably just hanging there open. And once I got postmenopausal and started doing regular Mona Lisa, my UTIs disappeared after a lifetime. Because
I'm glad for you.
Yeah, she tried to build up the collagen specifically around my urethra to build it up.
So she, and I commend her.
Yep.
She went off label, but with a very, very specific indication.
Yeah.
But what they're claiming it does, like reclaim your sex life and do all this stuff. I'm waiting for the Food and Drug Administration or the American College of OB-GYN or the North American Menopause Society to give the green light. But right now they're like, there's just not enough evidence to blanket, advise this for everyone.
For everybody.
Not when estrogen works beautifully for the majority of patients.
Vaginal estrogen and Astroglide. Those are the two things I'm going to say when I make that phone call to my doctor. Okay, so
now Astroglide and Uberlube are over the counter. You can just go on Amazon and buy them right now.
That's right. Oh, I can do that right now as we speak. Okay, so let's talk about the relational things. I always say that when Till Death Do Us Part was invented, death was pretty imminent. That people before, wide use of infant vaccinations, not everybody made it to adult life. Men were dying in wars, women were dying in childbirth. And now we have these super long life expectancies, and people have this idea that their relationship should endure 30 or 40 or 50 or 60 years like their grandparents or great-grandparents. But in fact, if you keep that ideal in your head, you're more likely going to feel like a failure. And people will use that language all the time. They'll say, oh, yeah, that marriage failed. And I'm thinking, it was 20 years long. That was pretty successful, right, in today's time. And so I think even the most monogamous of humans, and anthropologists speculate it's about 50% of us, may find themselves having 2 or 3 long stints of monogamy with some mate selection in between. We call that dating. So when a postmenopausal woman comes to you, ready to enter the dating scene, do you ask her, or do you help her understand the changes in her body? And do you talk to her about how to discuss this with potential dates? And, what happens when somebody is single and dating and 55?
So I do try to broach that topic. It's most women at that age who were new to the dating scene, especially after a long prior relationship, are very nervous and anxious about all this because there's now apps. They're trying to navigate the new way to date via, going online and putting in profiles. But I do try to talk to them about things I would talk to any person who was in the dating field, sexually transmitted disease prevention, use of condoms, what they're really good for. And I have to add another layer on, things aren't the same down there. So, in the vaginal vulvar area. So what things can we do to protect the area so it is comfortable? So yes, I do try to broach that with my patients and give them some advice and tips and tell them, if lubrication is not enough for you, please come back because we need to talk about estrogen at that point.
And the other thing people don't talk about is we think that condom use is for the young who are trying to prevent pregnancy. And I have heard,
condoms are the worst way to prevent pregnancy.
Oh, all right. Well, Dr. Mary Claire Haver, I want to ask you if this is true. Some OBGYNs have been telling me that there's been actually an increase in STIs in the postmenopausal group because women are taking off condoms because they're not worried about fertility issues.
So I definitely see postmenopausal women coming in with STIs, mostly trichomonas, occasionally herpes, a new onset of herpes. And of course, they're devastated. They just couldn't believe that this could happen. And so, my job is not to make them feel any worse than they already do, just to, and then how can we make a path forward with them and what things, if I can get them before this happens, when they're new on the dating scene, I always discuss condoms for STI prevention. I'm like, don't think that these things aren't out there, because they absolutely are. And you're just as vulnerable as a teenager to these infections. And here's how the best way that we can protect you.
One of the things I often tell women, too, because one of the most common questions I get is, Dr. Wendy, what do you think about sex with your ex? And all my response is always put a condom on, because the fact that they're an ex tells me that you're not monogamous with them. So be careful. And of course, I don't like them to reignite old feelings and then have to withdraw from that person again. And it's like breaking up over and over. But it's what people like to do. Okay. Is there any parting advice that you would want to give older men or women as they embark on having enriching, exciting sex lives over the age of 45?
Your sex life can be just as fulfilling and enjoyable and beautiful as it was when you were 18. It's just a little different. You have to approach it differently. You need to be accommodating. You have to realize that the anatomy has changed, but it doesn't mean that you can't have an incredible, maybe even better, loving, connecting, fulfilling, experience with your new partner that you've, maybe even better than you've ever had in your life. It's just going to be a little bit different.
And I also remind people that the hot, exciting love relationship that you had years ago sometimes turns into a wonderful, mature, companionate love. And that your love is not less if your body has changed and you've chosen to have different kinds of sex. All sex is good sex. I mean, I have a friend whose husband has lost some function. So she says, we don't have intercourse anymore. We have outer course. Right?
I love that. Outer course.
Outer course. So adapting it in a way that works for everybody is what love is about.
Yes, absolutely.
Learning how to adapt. Well, I'm a big fan of yours, and I hope everybody listening to this episode of Mating Matters goes to find you online. You have a great and very informative social media presence, particularly on TikTok. Dr. Mary Claire Haver is the name everywhere, Haver. And thank you for being with me today.
Oh, thank you so much.
Always a pleasure. Thanks for listening to this episode of Mating Matters. I'm Dr. Wendy Walsh. You can always listen to the Dr. Wendy Walsh radio show on the iHeartRadio app, but we'll have more episodes of Mating Matters for you right here. Thanks for listening.